There are two interesting scenarios of that they've identified through some great research, looking at how our body detoxifies the carcinogens. So detoxifies these occupational exposures or smoking that we're exposed to. The NAT1 and NAT2 genes both detoxify these aromatic amines that cause bladder cancer. And what they found is that some people, not very many, but some have a mutation in these genes that leads them to detoxify slower. So the toxins in their system, and rather than breaking it down at a normal rate, the mutation causes them to break it down slower. So there's more exposure to that individual carcinogen. And especially in those that are smokers, there's an increased risk of bladder cancer that has been observed. And then there's another gene, which actually is fairly common in Caucasians in the United States, a mutation in the GSTM1 gene, which also works to detoxify carcinogens in the urine. And although it's relatively common, it doesn't have that big of that commonly lead to bladder cancer, but there does appear to be an increased risk of bladder cancers in those that have this gene. Now, neither of these are common enough that we're going around looking specifically for these mutations, but it is interesting how, especially where you can see the genes that we have and the environment that we're exposed to can lead to cancer. But again, not very common. This slide shows what we more commonly encounter in bladder cancer. This is from the Cancer Genome Atlas. There's a tremendous amount of data on this screen. This is what our people's publications look like that we read about bladder cancer. And these are a bunch of somatic mutations that occurred in the tumor themselves that then led to the bladder cancer. So P53, ARID1A, these are the genes that we see, not that they're inherited or that they're born with, but that develop in the bladder tissue and lead to tumor. Most of these bladder cancers occur that way. So what about prevention? We all want to do things that we can help to prevent from getting cancers, and there's been quite a bit of research looking at this area too. And I want to define two different types of prevention. There's first primary prevention, and that's where we take people who don't have the disease, who don't have bladder cancer, and try to do something to prevent it from occurring. The other is secondary prevention. So that's in the scenario where someone has had the disease, someone has had bladder cancer treated, and we're trying to do something to help prevent the disease from recurring. That's called secondary prevention. So taking a look at primary prevention first, there's no clear evidence that that there is a specific item we can do to help prevent bladder cancer from occurring in those that don't have it. There have been very large studies looking at vitamin A. It's called the ATBC study, 29,000 male smokers looking at vitamin E and beta carotenes to see if they could reduce the incidence of cancers. Did not see a reduction in the incidence of bladder cancer. Selenium in a large study, the SELECT study, also looked at vitamin E2. Very large studies, tens of thousands of patients, where we have not seen a reduction in the development of bladder cancer. Certainly multivitamins. Many of you are aware of the large study looking at a multivitamin that overall reduced cancers, but and maybe in part there's not enough events and enough bladder cancers themselves have not seen a convincing reduction in multivitamins and bladder cancer. And some of these studies are just limited by the fact that you're studying a large group of people, but you have to have enough events, enough people develop the tumor to be able to show statistically that there is a difference. And I think that the other thing that these studies do show too is that at higher levels of some of these supplements, they can lead to other adverse events too. So I think everything in moderation. I have had an interest in looking in this as well, again with Dr. White and some other researchers, where we looked at a study looking at supplemental vitamin use and minerals, and we did not see a reduction in the risk of bladder cancer in this large cohort study where they were looking specifically at vitamin use and lifestyle and development of different cancers or other different diseases over time. Non-steroidals have had a lot of interest in them. These are the anti-inflammatories. As I mentioned earlier, inflammation can be one of the hallmarks that can lead to development of cancer. And could non-steroidal medications help reduce it? There's mixed results. There have been some studies showing a reduction among non-smokers. And this is a study that we did, if I can get to come back up, where we looked at whether or not long-term anti-inflammatory or NSAID use was associated with bladder cancer. And we saw a reduction in a subset of patients in those that had quit smoking. So maybe similar to what the other studies had shown, where this was non-smokers having a reduced risk, and we were seeing in those that had quit smoking 10 years before. So we see a lot of this in these prevention studies, a hint of something, but not conclusive. Now, secondary prevention, I am not talking about like BCG or mitomycin or gemcitabine that a patient may receive from their physician as an active treatment to prevent bladder cancer. That is a secondary prevention, but I'm just going to focus on non-therapeutic interventions that the physician might give. And there have been several randomized studies looking at these. These are some of the more common ones. Retinoids, again. There was some pretty exciting preclinical data about retinoids and prevention. Unfortunately, in the studies that they did with some synthetic retinoids, there actually were more adverse effects in those receiving them and thus not used. Vitamin B6, very small study showed an effect, larger study did not. Again, here's the NSAIDs again. Interesting studies looking at mega multivitamins associated with BCG. One small study showing an effect, a larger study, randomized study showing no effect. So conflicting data about things. And similarly, we talk a lot about just increasing your fluid intake. Can you dilute out the toxins better or flush them out better by drinking more water? Certainly a fairly easy thing to do to try to help prevent cancers, bladder cancer. And there has been one large study, observational study, that did show an effect, although a more recent longer-term follow-up of that study did not show as much of an effect there. So again, unfortunately, despite significant effort looking at different things, we do not have convincing evidence that different items are useful for secondary prevention of bladder cancer. Not to say they're bad for you, but we haven't seen we don't have enough data to conclusively say something. What do I tell patients for prevention? Smoking cessation, that's number one. Stop smoking, or if you're exposed to secondhand smoke, reduce that as well. A healthy, well-balanced diet. Most of us don't get the 5 servings a day of fruits and vegetables. We don't eat enough complex sugars as opposed to simple sugars. We need to eat, and then trying to reduce some of our fat intake. All these things that are certainly helpful for not only our heart, but also likely helpful from the development of cancer. Exercise, there's certainly something about the immune system and having a better immune system with exercise and other different pathways as well, and weight loss too. So basic recommendations, but are heart healthy and good for you and bad for cancer. And I like that combination. So certainly things that we all can do. And then briefly, screening for bladder cancer. At this time, it is not recommended that we do routine screening for bladder cancer. The way we would be screening is primarily looking at a urinalysis for microscopic hematuria. Other things like routine cytologies are definitely not recommended. The U.S. Preventive Services Task Force, the National Cancer Institute, the American Cancer Society do not recommend screening. I will point out, this is regarding screening in asymptomatic adults. So that's someone that has no symptoms. If you come in with symptoms, different story. But this was the language. Insufficient high-quality evidence that screening improves outcomes in bladder cancer and would result in unnecessary testing in individuals with associated risks and morbidity. So at present, we do not recommend routine screening for asymptomatic adults. There are scenarios where, although there aren't clear guidelines, we do think, or many of us believe, that there is a role for screening in very high-risk individuals. Obviously, someone with this Lynch syndrome, inherited syndromes, where there's such a high risk of developing bladder cancer, to watch those patients. Urinalysis versus cystoscopies, or there's debate about what the best way to do it is. Bladder cancer birth defects that have these augmentations, especially those with gastrocystoplasties, the stomach augments. And then also the discussion of what to do if you have someone that's a very high smoker who is catheter dependent, recurrent UTIs. You know, is there a role there? Can't say there is, but I think we can take on a case-by-case basis and look at someone's exposures. If we knew they were exposed to a highly contaminated well with arsenic, that's someone I would certainly consider doing some screening on, different than the asymptomatic person. This is the main thing that most of you listening here know, is that when you have hematuria, you need to go get it checked. Gross hematuria, or red urine, the blood you can actually see in the urine, about a quarter of these patients are going to be found to have urologic malignancy. It could also be kidney, urethral, ureteral. And even another 20% have a benign urologic cause. So gross hematuria needs a workup soon. Microscopic hematuria, much lower prevalence of finding bladder cancer, but still, when we see patients that have microscopic hematuria, the recommendations are for an evaluation, especially in someone's older and has been a smoker. We can get up to a 5% risk or higher of those individuals having bladder cancer found on the workup for microscopic hematuria. And we do a lot of trying to educate our primary care colleagues, if they happen to be getting a urinalysis on an individual as part of their care, and if they see microscopic hematuria, to not ignore it, but to then refer to a urologist for discussion of evaluation. So in conclusion, bladder cancer is common. It's one of the, like I said, number 6 cancer overall, not just in the U.S. but worldwide as well. There are specific epidemiologic features. It's common in older, but affects all ages, affects both genders, but is more common in males. There are race differences, but all races are affected. Smoking and occupational exposures are the primary risk factors that we have identified. Unfortunately, we don't often know what exactly caused the cancer in an individual, but certainly there are occupational exposures, and work on smoking cessation. There's no established prevention at this time, but again, I really advocate for a healthy lifestyle, which is certainly going to be good for you in many, many ways. And at present, asymptomatic, so those without symptoms, screening is not recommended. And so with that,